Good evening, everyone. We welcome you all to OrthoTV in association with Universal NutriScience. To introduce today's speaker and the topic, I hand over to Ms. Vaishali from UNS.
So thank you, Dr. Neeraj Bijlani. So good evening, everyone. I myself, Vaishali Waghela, Senior Product Manager, who is welcoming all of you to the platform of webinar, which is organized by Universal NutriScience. And to give you a little bit background about in this today's time, the current situation, India is reaching approximately a 60 million osteoarthritis patients by 2025.
Everyone,
With this, actually, the therapeutic management of osteoarthritis is the top of a mind for the many physicians. In the recent years, like UC-II, which is a type 2 collagen, has gained importance as one of the options for managing OA.
in this
time, today we have partnered with Lonza, which is actually a preferred global partner for pharmaceutical and biotech and in delivering a new and innovative medicine. And for our brand, universal brand, which is Collagen, which actually contains Lonza's collagen, which is actually backed up by clinical evidence. And as our topic for the day suggests, the objective of this webinar, which is to define the role of a UC-II, which is in the management of osteoarthritis. So I would like to introduce our Dr. Zain Saiyed, who is a director actually in the Lonza's capsule and the research and the innovation team, and who is actually who has earned a PhD in biochemistry and nanomedicines. Also, who is responsible for the technology expansions with the Lonza, who has the experience of 15 years in developing and doing the research in the ingredients and also for developing the joint related solutions, also for the sports, nutrition, metabolic health, and the stress management. And he has also published a lot of papers and book chapters in various platforms. He will be actually talking about the mechanism of action of a UC-II, and who will be actually giving us a little bit, who will throw a light on clinical evidence of this molecule. And also with this, I would like to introduce Dr. Anish Desai, who is actually currently a medical advisor with Universal NutriScience, who is associated with pharma industry from last 25 years. And also in the past, he was a medical director with J&J and also headed the division in Bayer. Currently, who is a honorary professor for pharma medicines with Maharashtra University in Health Science. So thank you all of you. I would like to hand over this session to Dr. Anish to proceed ahead for the program. Thank you.
Thanks, Vaishali, for the introduction of the topic and Dr. Zain. Good evening, everybody, to the esteemed panelists and to all the viewers of the webinar. I invite you for this session. So we are going to have first a talk from Dr. Zain, and then we will have a panel discussion with our esteemed group of panelists which are there. So Dr. Zain, who, as Vaishali mentioned, has been an esteemed researcher with Collagen, and we would like to hear from him in terms of what has been his experience in R&D, in terms of the UC-II, how UC-II, the mechanism of action of UC-II, the clinical evidence available with UC-II, and how exactly UC-II has been studied extensively in clinical settings of management of osteoarthritis. So I hand over to Dr. Zain to take us forward and enlighten us on his research on UC-II.
Thank you, Dr. Desai, and thank you, Vaishali, for the kind words. Let me first share my screen and see if you all can see my screen.
Yes.
Excellent, thank you. All right, so I would start first with thanking Universal NutriScience for organizing this event and giving us an opportunity to speak about UC-II undenatured type 2 collagen and its role in management of joint disorder, which is osteoarthritis in this case. With that brief introduction, let's begin, or let's dive into today's presentation. So today's agenda, what I'm going to do, I kind of divided the talk into two phases or two parts. The first part, I'll give a very brief overview of osteoarthritis pathophysiology, and to this audience, introduction to osteoarthritis is absolutely not needed, but so I'll keep it very top line. But what I'll be doing more is talking about how UC-II undenatured type 2 collagen, the mechanism by which it works and exert all its beneficial effect. So that's the first part of the talk. And then the second part is where I'll highlight some of the selected clinical study that has been used to show the safety and effectiveness of UC-II undenatured type 2 collagen. So let's begin with the first part, which is the OA pathophysiology and role of undenatured type 2 collagen. This slide shows how prevalent osteoarthritis is. We all know about the global pandemic, which is COVID, but there is a lesser known pandemic in the world that is osteoarthritis. And it has been estimated that by 2025, there will be 60 million osteoarthritic subjects or patients in India. And globally, by the end of 2021, there were over 86 million people in the world who were living with knee osteoarthritis. The slide on the right also shows the distribution or the prevalence of osteoarthritis in different states. In India, with AP leading, followed by Assam, Delhi, Karnataka. So overall prevalence rate in India, as I read from the National Health Portal, is ranging from somewhere between 22% and 39%. So when we talk about the pathophysiology of osteoarthritis, I think there are two mechanisms which kind of plays the role. One is the mechanical pathway, which is the mechanical wear and tear as we age, which leads to damage of the cartilage and eventually resulting in release of some of the cartilage material that acts as antigen and engages the immune pathway, leading to production of inflammatory cytokines, IL-1 beta, TNF alpha, which further accelerates the cartilage breakdown, eventually to a point where the bone starts rubbing against each other, resulting in joint pain, stiffness, and limited physical activity. What is the current standard of care for osteoarthritis? We all know it all starts first with exercise, especially muscle strengthening exercise, which allows for improved joint flexibility. Then the pain relievers like the paracetamols or the NSAIDs or the topical lotions or creams, which are anti-inflammatory in nature, which relieves the pain, just the symptom, but not the cause. And then in many cases, it's the intra-articular injections or viscosupplementation with hyaluronic acid. And then the last category, which is mostly used as a preventive or also during the initial management of OA, is dietary supplements, which is glucosamine chondroitins or herbal extracts like boswellia or rosehip. And here also, I would mention that dietary supplements, collagen-based dietary supplements are used. So the topic of today is we are going to zoom onto the collagen dietary supplements, and especially we'll focus more on the undenatured type 2 collagen. So before I dive into the mechanism, I always like to present this slide, which is a very high level kind of classification of collagen products that you see right now in the marketplace or in the pharmacies. So there are two main types, undenatured or native type 2 collagen, where the native structure of the type 2 collagen is preserved. You can see that on the left side of the screen, where you see the triple helix of the type 2 collagen is intact. This is achieved by using a manufacturing process that is very gentler, so it does not involve use of heat or enzyme, and that allows the protein to stay in its intact state. Whereas the other type is called as denatured. And as the name suggests, denatured is where the structure of the protein is disrupted. And again, denatured can be classified as gelatin or hydrolyzed collagen, and it either it's in the form of a peptides or polypeptides or amino acid, which are the building blocks of this protein. So the way I kind of explain this is on the left, where we have undenatured type 2 collagen. It's like a raw egg where the protein is all intact. Gelatin is where it's like an omelet, where the protein has got denatured, and hydrolyzed collagen is more of basically it's a chopped up omelet, basically, where we have all the proteins broken down into individual component. And what we'll focus today is the undenatured part, the one on the left. And what is undenatured type 2 collagen? It's the next generation of solution for joint health and mobility. And because it is it has an undenatured or native structure, it retains something called as epitope, which are the antigenic determinant, or which are the structures or sequences on the protein which engages the immune system in the body. So because UC-II or undenatured type 2 collagen is manufactured by low temperature processing method, it has those epitopes, and those epitopes are very important when it comes to the mechanism of action of this molecule. It works via a unique mechanism called oral tolerance, which I'll be talking about in the next slide. And the picture on the left bottom shows the transmission electron micrograph of the UC-II collagen, and you can see the collagen fiber right there, which is in the green highlighted area. So before we jump onto the oral tolerance, a very brief background on the physiology of the gut. There is 70% of the immune system resides in the gut, and specifically highlighting the gut-associated lymphoid tissue, which is a clumped collection of immune cells. And the role of GALT is to monitor the gut. It's basically policing the gut for any harmful substance or bacteria, and basically deciding whether to mount an immune response, and also kind of protecting the alimentary tract against untowards immunological damage. So UC-II, how does it work then? So when we consume UC-II, it passes the stomach acid, and what has been known is collagen, when it is in native state, it is quite a sturdy protein. So it survives the acidity in the stomach, passes and arrives in the small intestine in this area of Peyer's patch or GALT, where it is taken up by a specialized class of dendritic cells, CD103 positive cells, and through a cascade of signaling mechanisms, it leads to induction of specific type of T cells, the T regulator cells. And these T regulator cells that are generated in the gut, in the Peyer's patch, in response to type 2 collagen, basically escape the gut into the systemic circulation. And when they arrived at an overstressed or inflamed knee, they get activated. The characteristic of this T regulator cell is they secrete anti-inflammatory cytokine IL-10 and TGF-beta. And both these cytokines, as the name suggests, anti-inflammatory. So one is they will offset the inflammation. Second is they will direct chondrocytes, which are the resident cell in the joint, to make new extracellular matrix material, thereby allowing the building of new cartilage material. So quite an interesting mechanism. A lot of research is being done. T regulatory cells currently in immunology field are researched for different benefits, different application. And in this case, UC-II collagen is able to induce this T regulatory cell in the gut because of its native structure. This mechanism will not work if the collagen is denatured or hydrolyzed. And that's a perfect segue to some history, how native type 2 collagen concept came into existence. So this study was done back in 1987 at New York School of Medicine under the supervision of Nagler Anderson and her group. So this was an interesting study, and one of the pivotal study that kind of showed that native type 2 collagen has a protective effect against arthritis. This study was done in a mouse model, in a DBA1 mouse. It's a collagen-induced arthritis. It's a polyarthritis model whereby the mouse is immunized with native type 2 collagen intradermally, but before they are immunized, they are orally fed solubilized native type 2 collagen. So the first chart on the left basically shows that mouse that had received native type 2 collagen had a significantly lower incidence of arthritis. The second chart shows there was a significantly lower severity of arthritis in the mouse receiving native type 2 collagen. And then the right chart on the extreme right basically shows that mouse that received type 2 collagen that was denatured by heating it at 56 degrees C did not have any protection against collagen-induced arthritis. So this was the pivotal study that was done back in 1987. After that, a lot of studies has been done at Harvard Medical School, where they have shown the benefits of type 2 collagen in management of osteoarthritis as well as RA. Here at Lonza, we continue to do a lot of research, trying to understand further the mechanism. And just last year, we also did a monoiodoacetate induced OA in rodent model, where we saw that rats that were supplemented with UC-II equivalent to 4 milligram per kg bod, which 4 milligram per kg body weight, which translates to 40 milligrams per day human dose, had a significantly lower articular cartilage damage as seen by reduction in COMP. COMP is cartilage oligomeric matrix protein, which is a marker of cartilage breakdown. It was significantly lower in these rats that had received UC-II versus the control. There was also significantly lower inflammatory markers like IL-1 was downregulated, IL-6, TNF-alpha, and CRP. And when it came to the osteoarthritis severity or grading, we saw on a radiological screening that UC-II receiving animals had significantly lower KL score or lower OA damage. And that's the chart on the right. You can also see some of the radiographic pictures, which shows that groups that received UC-II had lower OA severity and symptoms. So that's kind of the first part of what exists in terms of the mechanism. As I mentioned, UC-II works by a unique mechanism. Just want to recoup that is oral tolerance, and it is only possible with native type 2 collagen protein. It's not possible with the denatured collagen. The example I was giving, the omelet and the scrambled egg, that's the hydrolyzed collagen part. So it only works with the native or the raw egg kind of thing. And I use example of the egg just to kind of explain in a layman term, but it's this particular collagen comes from chicken sternum cartilage. So I'll move on to the next portion, which is the science that backs up the efficacy of undenatured type 2 collagen. There are 11 human clinical study publications. We have been researching this collagen for 20 plus years now. And here is a nice slide that shows how the science of UC-II collagen has evolved in this 20 plus years. So it was discovered back in year 2000 by a chemical engineer, Dr. Moore, who was looking for a cure for his daughter who had rheumatoid arthritis. And basically he converted his kitchen into a small lab. He tried different preparations of chicken, and he found that when he was not cooking the chicken and trying to basically make an extract of this chicken, his daughter felt better. And then the same preparation, he gave it to his friend who had osteoarthritis, and Roger, his friend's name, also saw the same benefit. And building on that, Lonza has continued to develop more science. Some of the earlier studies were done in 2002, which was the first pilot, which showed the unique mode of action, how UC-II works, and it also showed that it reduces joint discomfort in subjects with arthritis. And then the two key pivotal study that I would like to highlight is 2013. To the best of our knowledge, when it comes to the nutrition industry, we were the first to show that UC-II undenatured type 2 collagen can help improve joint function in healthy subjects who experience pain upon physical activity. Then in 2016, we did a rather large study for a nutrition industry, about 200 subjects, and showed that UC-II is significantly better than 2.7 gram of glucosamine and chondroitin. This was also a gold standard randomized double-blind placebo-controlled study, which I'll refer in a few slides. And then very recently, just last month, we published two publications. And this was a study, again, this was our second study done in healthy subjects who experience pain upon physical activity, where we showed that UC-II improved knee joint flexibility, as well as UC-II receiving subject were able to walk more. So they took significantly more number of daily steps. This is just an eye chart. I won't go through it, but just to give you a perspective, we have 8 publications, clinical study publications done in osteoarthritic subjects, and 3 done in healthy subjects who experience pain upon physical activity. So let's dive a little bit into the 2016 osteoarthritis study. This was a study where the objective was to evaluate the efficacy and safety of UC-II collagen in modulating knee osteoarthritis. This was a multi-center randomized double-blind placebo-controlled study done in India at 13 clinical sites. And here on this slide, you can see the study design. There were 3 groups, one group receiving placebo, another group receiving glucosamine, 1500 milligrams, and chondroitin, 1200 milligrams, so total 2.7 gram of glucosamine and chondroitin. And then the third group received UC-II 40 milligrams per day. There were 186 subjects, so about 55 to 60 subjects in each of the group. The study population was moderate to severe, grade 2 and 3, based on the KL score. And the primary endpoint was the change in total WOMAC at day 180 versus placebo and GC group. What we saw here, the chart shows the data for the WOMAC, and the green line shows the data for subjects who received UC-II. What we saw was UC-II significantly reduced WOMAC score. As early as day 60, we saw a significance versus the placebo group, which is the blue line. And then by this improvement or this reduction in joint discomfort continued as the time progressed. And by day 180, we saw that UC-II was significantly better than placebo and glucosamine in reducing joint discomfort and improving joint flexibility. What we also did in this study, we did some sub-analysis, and we had done the COMP, which is cartilage oligomeric matrix protein, a marker of cartilage breakdown. We checked its level at the baseline, and when we looked at the population, we saw that 285 nanogram per mil was kind of a median of this population, and we wanted to see how the efficacy was in subjects whose COMP was less than 285 nanograms and subjects whose COMP was more than 285 nanograms per mil. And when we did this sub-analysis, we saw that the WOMAC score was significantly lower in subjects whose baseline was above 285 nanogram. Now, from the clinician standpoint, this is very important because I know from the orthopedic and rheumatology side, you are more familiar with ACR 20, ACR 40. And here, when we looked at the net difference versus placebo, UC-II being a supplement, we saw a net reduction of close to 16%. So UC-II receiving subjects sort of 16% reduction in WOMAC versus what was seen in the placebo group. And this is very interesting, where we were trying to tease which subpopulation had the most effect. And on this, this study was co-authored by Dr. Nancy Lane. She's a rheumatologist here at UC Davis, University of California, Davis. And she was also a co-author on the GATE study, as many of you might know. That was one of the largest trials that was done with glucosamine and chondroitin back in 2006. And in generality, the trial kind of showed that GC was not that effective. So in addition, one more point that I would mention is here we did all the analytical testing methods as well as the statistical modeling and COA, which is analysis of covariance, MMRM, and incremental area under the curve. These are all gold standard statistical methods to check whether the molecule has an efficacy or not. And in all this statistical modeling, we saw a significant reduction in joint discomfort in the UC-II group versus placebo and GC. So kind of a cool outcome. We also checked the rescue medication. The subjects in the study were allowed to take 1 gram of paracetamol as a rescue medication. And what we see here, if we just see the last row of the table, when we looked at the entire study period, there were only 11 subjects out of 63 in the UC-II group that needed rescue medication during this 180-day study period, versus placebo, there were 28, and GC, there were 21. So more UC-II had significantly less than half of the subject using the rescue medication or needing rescue medication versus what was seen in the placebo and GC group. So moving on to next study, which is also a multicentric real life study. This was done again in India. This was done independently. And the objective of this study was to, again, check the safety and effectiveness of undenatured type 2 collagen in management of osteoarthritis. This was done at 18 orthopedic clinical sites in India. This was a 90-day study, and this was longitudinal study where subjects' WOMAC scores and VAS pain scores were measured at baseline and then at day 30, 60, and 90. What we see here is UC-II, after UC-II supplementation, we saw a significant reduction. As early as day 30, we saw a 13% reduction in WOMAC score as well as in VAS pain score. And then as time went by, there was this improvement kept on increasing. So by day 90, we saw a 40% reduction in WOMAC score as well as 52% reduction in VAS pain score in this osteoarthritic subjects. The second real life, or the third real life study that I would highlight here is a study that was just completed and published 5 months back, which is in January of 2022. This study was done in Ukraine at University of Kyiv. And this was again done independently of Lonza by one of the pharma company that markets this molecule in Russia and Ukraine. The objective of this study was to see efficacy, safety, and how UC-II influence the cartilage metabolism. So this was the first study that showed the impact of UC-II on the cartilage structure. So the structure modifying effect of UC-II. It's quite exciting from the science standpoint. Here, the study, in this study, there were 30 subjects that received 40 milligram of UC-II for a period of 24 weeks. And this subject, who were grade 2 and 3, as measured by radiographic score, showed that at the end of 24 weeks, the cartilage thickness, as measured by ultrasound, was significantly higher. There was a 17% increase in cartilage thickness, was in the UC-II group. And this is important because increase in cartilage thickness suggests cartilage regrowth and cartilage repair. And similarly, as we see in the previous study, we also saw a significant reduction in WOMAC score. So there was a 33% reduction in WOMAC score at the end of 24 weeks in the UC-II receiving subject. So we are quite excited that this is first time in human we have seen a structure modifying effect of UC-II, that is increase in cartilage thickness in addition to the clinical outcomes, which is reduction in joint pain and discomfort. So with that, I would summarize my talk. UC-II Undenatured type collagen is the next generation of joint health ingredient. It works with the immune system via the unique mechanism of oral tolerance. And what is required is only one small 40 milligram per day dose. So also from the patient compliance standpoint, taking one small pill is much better than taking glucosamine and chondroitin, which here in the US, we say it's 3 big giant horse pills. So it's always easier for patient to take one pill compared to 3 big pills. And finally, as I mentioned, UC-II has science backed by 11 clinical study publication done in osteoarthritic subjects and also in healthy subjects who experience pain upon physical activity. So I'll stop here and see if there are any questions.
So thank you, Dr. Zain, for your interesting presentation. In fact, post your presentation, I think we will get into a panel discussion with our esteemed group of panelists. And that's where we will have some questions answered by the panelists. So
I'll stop here and see if there are any questions.
Yeah, so Dr. Zain, for your interesting presentation. In fact, post your presentation, I think we will get into a panel discussion with our esteemed group of panelists. And that's where we will have some questions answered by the panelists. So
I'll stop here and see if there are any questions.
Yeah, so Dr. Zain, for your interesting presentation. In fact, post your presentation, I think we will get into a panel discussion with our esteemed group of panelists. And that's where we will have some questions answered by the panelists. So
I'll stop here and see if there are any questions.
Yeah, so Dr. Zain, for your interesting presentation. In fact, post your presentation, I think we will get into a panel discussion with our esteemed group of panelists. And that's where we will have some questions answered by the panelists. I think there is an echo which is coming up, so I hope that gets sorted out.
Actually, Dr. Sardar, if you can help us in, the speaker, I think so. We are kind of having some kind of a problem with the speaker. So if you can check once, sir, from your side.
So I think if there is no issue, let me start with the introduction of the panelist. So am I audible to everybody?
Sure,
Yes,
sure, Dr.
yes, yes.
Thanks. So let me first introduce our first panelist, Dr. Ram Prabhoo. Dr. Ram Prabhoo is a senior orthopedician, spine, trauma, and sports surgeon who has been practicing for years in Mumbai. He has delivered several lectures. He has been responsible for holding more than 200 workshops and taught more than 4,000 or 5,000 surgeons all over the country and in Asia Pacific. He's been the past president of Bombay Orthopaedic Society. He's been the past vice president of Asia Pacific Orthopaedic Association, also the president of Indian Orthopaedic Association. The next I would like to call upon Dr. Subhash Jangid. Subhash Jangid again is a senior joint replacement surgeon and sports medicine and injury orthopedic in Gurgaon, India. Dr. Subhash Jangid is currently working as a director of orthopedics and joint reconstruction at FMRI Gurgaon. The next panelist that I would like to call upon is Dr. Indrajit Sardar. He is a senior orthopedic surgeon from Kolkata, India. Has more than decades of experience in orthopedics, trauma, spine, and he has been among the first few to be responsible for performing cell transplant surgeries. Next, I would like to invite upon Dr. Gokulraj Dhanarajan, a senior consultant orthopedic surgeon from Chennai. He's again, area of specialization includes joint replacement and acetabular reconstructions of hip and knee. He's also experienced in hip and knee replacement surgeries. He is been trained in the Indo-German Orthopaedic Foundation. Next, last but not the least, I would like to invite Dr. A.S. Prasadt, who's an orthopedic surgeon from Kanpur, India, and has been organizing joint replacement training programs and orthoplasty courses in India. So with these panelists, we would like to start our panel discussion. And I have few questions which I would like to address to this esteemed group of panelists at this point of time and see their interactions and their experiences. So Dr. Ram Prabhoo sir, the first question that I have is for you. I would like to see, know your patient experiences with UC-II, because this product has been in the market, and you see several of these pre-joint replacement patients. You see a lot of orthopedic patients. So what is your experience with UC-II in OA, and how have your patients responded to these UC-II treatment in your practice?
Yeah, so thank you, Dr. Anish, and thank you very much, Dr. Zain, for your inputs. It was a really excellent lecture. We have used UC-II for last almost 5 years, little more than that. And I personally have done some studies. I have also done some research on it. I have also published a paper on this. And I have realized that the value of UC-II in osteoarthritis, particularly in, if you call grades of osteoarthritis 1, 2, 3, 4, in 2 and 3 grades. In the final, the most advanced is the severe form. It doesn't really help, but rest of the things we have been extremely happy with the results that have been shown by the patient's improvement, and patients have been happy. Of course, you need to give the adjunct therapy like physiotherapy, exercises, and that has to be supplemented to this. You cannot have standalone UC-II given to the patients and expect for the miracle. So we need to look after the muscle strength, strengthening exercises that needs to be done. We have to give sometimes some kind of analgesics to start with, but as and when the patient is sort of pain-free, we could just continue on UC-II. We have supplemented analgesics and some kind of anxiolytic agents also, and that has really helped. But UC-II, my experience is really fantastic, and I would recommend this. I have given it to lots of my relatives also, and they have been extremely happy.
Thank you, sir, for your response. Dr. Sarkar, sir, my next question would be to you. And I would like to get your opinion in terms of how would you advise your colleagues and your juniors to the role of UC-II, the use of it in their patients?
I have given it to lots of my relatives.
Am I
also,
audible?
and they have been extremely happy.
Am I audible?
Yes, sir. Yes, sir.
Thank you, sir, for your response.
Well,
Dr.
I think the
Sarkar,
same
my
thing
next
with
question would be to you.
has said.
And I would like to get your opinion in terms of how would you advise your colleagues and
Are you getting an echo?
to the role of UC-II, the
I don't
use
know
of
what
it?
You know, the recorded version is echoing again.
Yes, yes.
Whatever has been recorded is again coming back.
Yes, sir. Yes,
While
sir.
Dr. Sardar is talking.
Dr. Sarkar, my next question would be to you. And I would like to get your opinion in terms
So I would like to request Dr. Indrajit, can you just reconnect?
Are you getting an echo?
It's not his problem. It is a problem, as Dr. Prabhoo said, from the recording part of it.
Both are coming.
Yes,
Whatever has been recorded.
Okay, yeah. Dr. Anish, you can start.
Yeah, so sorry, Dr. Sarkar, sir. Can you please, again, I repeat my question, is what has been your experience and how would you like to counsel the newer physicians and orthopedic surgeons who would be wanting to use this product in their practice?
Dr. Anish, he is Dr. Sardar, Sardar of orthopedics, not Sarkar.
Okay. Thank you, sir. Sorry, sir.
Yeah, and he is our guru in a lot of matters of orthopedics.
I think he's got disconnected.
Then he was told to disconnect and connect.
Yeah. Vaishali told her.
Yeah, so you can ask somebody else a question, and Dr. Anish.
Yes, yes. So I would move on to Dr. Prasadt. Dr. Prasadt, my question to you is that what has been your experience with the patient in terms of their feedback, their response to the therapy? Probably you would have started UC-II post the patient maybe not having responded to the earlier treatment. So what has been your patient feedbacks in terms of this therapy?
In fact, I'm very happy, and I really use it in a lot of patients. In fact, there are three things which I can say. Number one, the subjective response of the patient is excellent. For 9 out of the 10 patients, they said they are better off as far as the pain is concerned. The other thing which we notice, the gait becomes better, the walking capacity increases. So they always come back and they say, now I can walk half kilometer, then it becomes 1 kilometer. So there's a gradual increase in the walking capacity as well. So I'm pretty happy with this. And it, frankly, I will not say how much, but it definitely delays the surgery, which I was always trying to do. And I'm very happy with the lecture, because when it says that the objective assessment of the thickness, increase in the thickness of the cartilage, that's very heartening. That was something new for us also. Because we always think that subjective improvement is there, but is there any structural improvement? So that study which the learned speaker mentioned, I think that's very hurting for all of us, that we will use this collagen with lot more confidence. But definitely subjective improvement is 100% there.
Thank you, sir, for your response. The next question I would like to address to Dr. Subhash Jangid. Sir, my question is that what's the kind of patient education that you need to do when you actually give him such supplements? And today we know that there are a lot of nutraceutical supplements available in the market. So what is the kind of patient counseling and education that you would suggest to all our audience?
So it's very, very important to explain the patient that what are the expectation out of this medication, because everybody thinks that this is going to rebuild the cartilage to the normal level, and that's not going to happen, right? Aging is a process and nobody can stop that. We are not God. So that I tell the patient very clearly that whatever we are doing, whatever we're giving to you, it's a multi-modality treatment. It's not just the medicine is going to work. So you need to do regular exercises. You need to build up your muscle strength, your bone strength. So if I see that the bone quality is poor, then I also add on the osteoporotic medication. And I tell them the discipline in life. So you need to be regular in your medication exercises. And how to take this? So I tell the patient to avoid any GI side effect. I tell the patient take this with the food. So take it with the food. So suppose you are taking the breakfast, lunch, or dinner, decide your food, whatever you want to take. Take it every day with the same meal. And suppose you are taking 2 chapatis or suppose a bowl of rice, then after half bowl of rice or 1 chapati, you take the tablet and then the rest of the meal. So that's how I advise. That has reduced the GI side effects significantly. And I have not come across many patients like that. You can count them on the hands that they have some GI side effects. As for the effect is concerned, because I have a practice where the patient also come for the surgeries and they want to try this before the actual surgical intervention. And I would say that in stage 2, it really works very well. Stage 3, I would say 70-80% has a good response, and they can delay their surgery. Definitely, no doubt about that. But it's a multi-modality, so I say that you have to take everything in one basket. You can't say just taking a pill and you'll be all right. That's not the case.
Sure. I understand. Thanks, sir, for your response. Next question is to Dr. Gokulraj. Sir, the question that I have again is that maybe it may be a repetition of it, but still in your experience, which are the group of patients who actually respond very well to UC-II? And at what stage of the OA's life cycle that we get a maximum and a best effect? I think Dr. Gokulraj, Vaishali, is Dr. Gokulraj there, or we have to skip the question?
Dr. Sardar, you can get it.
Hello.
Can you please Can you please give the Dr. Gokulraj?
Dr. Sardar is also there.
Yeah, Dr. Sardar.
Can you hear?
Yes, sir. Yes, sir. Sorry for the whole thing. And again, sir, the question that was there to you is what has been your experience in terms of UC-II with your patients, and how exactly do you really see the whole effectiveness of this product?
Well, the whole thing is that some other sound is coming. Anyway, from what we see is that, if we see 10 patients of osteoarthritis of the knee, you'll probably get 1 to go in for an operation. So the other 9 has to be managed in other ways. And one of the ways is, of course, what Prabhoo said, physiotherapy, exercises, change in lifestyle, etc., etc. And that is, of course, important. But more important is some sort of drugs, because people want to take a certain amount of drugs and hope that will help them. And the UC-II has been very good. The UC-II has really helped in many ways. It now comes in several combinations. It's very difficult to say whether it's a UC-II which is working. But one thing is significant, that once UC-II came in, the results have been better. Now, we don't have facilities to measure the ultrasound thickness or others, but we do find the only thing that works with us is the indexes. Maybe the VAS scale, maybe the Lequin index, all of this, or the WOMAC. These are easily done, can be done by talking with the patient. And the greatest thing, the patient comes, I'm feeling better. I can walk a little bit more, which corresponds with these indices. So my therapy would be for these cases we do not want an operation, or who do not qualify for an operation, is to put them on this with the other mechanisms. And this has given significant improvement in many of our cases. Not everyone wants to be operated. So the whole thing over there is very helpful. My recommendations would be for the UC-II to be given in almost all cases which are not going to be operated. We do not qualify for an operation, and we do not need an operation. And also there are people who don't want an operation. Now, obviously, in certain cases, they will have to go in for an operation. But a 3-month cooling off period with these medicines helps. And it helps in early stage 1, stage 2 with great effect. And there are many who have gone on for years. And I say this with some amount of authority, that I've used it for 6 months at a stress, given it off for about 2-3 months, and then gone on for 6 months on a stretch. And all of these people have improved enough to not come for the operation. Now that is a bit of a problem for knee replacement surgeons, but anyway, that's the way it goes. And our percentage of converting the knee replacements, the osteoarthritis knee, to replacement surgery or some other sort of surgery is much less. Is much less in that way. And then we get the genuine cases who have gone through the drug therapy and who are still motivated enough and to come and have genuine difficulties to be operated. This results in a better result for the satisfaction level in replacement surgery. Now, satisfaction level is something which replacement surgeons are worried about, because 20% there are unsatisfied patients. And if we can reduce that level by this sort of therapy, they are more convinced and their results are much better. If they have failed in one aspect, or if they improved in some aspect for years and then come in for an operation, the results or the satisfaction level or the satisfied level of patients undergoing care is also better.
Thank you, sir. Sir, a very interesting concept you mentioned, that patients who have been on UC-II actually have a better surgical outcome in TKR. Very, very interesting point again, which is there. So I think Dr. Gokulraj is there. Sir, can I address the next question to you? So just wanted to check your experience with the effectiveness and the safety of UC-II in terms of its onset of action, the duration, and the concomitant drugs that you have been giving, and how exactly you would like to, place your experience with this product in your patients. Dr. Gokulraj?
He is muted. Is he muted?
Yeah. Am I audible now?
Yes, sir. Yes, sir.
Yeah. Good evening, everybody. Actually, regarding the use of UC-II in case of osteoarthritis and tendinopathies, the effect has been very, very good. So that will be the first stay of my treatment for osteoarthritis as well as tendinopathies. Associated with, most of the time, I start them on analgesics, maybe in the form of aceclofenac, or in elderly patients, I just give them plain paracetamol or with tramadol. So this is the combination which I use, and the effectiveness on long run, at least for few months, the UC-II as a lone player helps the patients overall. Especially, we can, because some of our patients who are not willing for any immediate treatment for their osteoarthritis, UC-II along with other nutraceuticals are helpful to prolong their till they come back for other procedures like an injection or anything else like a joint replacement. This is what is my experience.
Sir, just one specific question is that what has been your experience in terms of the the onset of the action and the duration that you see in terms of your patient relief?
Minimum is about, I always tell them you have to take it for a month minimum, and then if they take and up to 6 months you need to continue it, and by 2 to 3 weeks is what we see some amount of effect for the patient. It is not immediate.
Understand, sir. Dr. Zain, you being the expert and having done a lot of research on UC-II, I would like to address the next question to you and check what are your views on terms of the dosage and maybe any drug-food interactions and duration of UC-II treatments in OA and at this point of time. So what are, as an expert and based on your experience with a large number of clinical studies, what would you be your recommendations to the audience?
Well, thank you, Dr. Desai, for the question. And first of all, I'm very thankful to the expert panel here. And it makes me very happy to hear from the clinician standpoint the benefits of UC-II that their end patient is able to get. So that is quite rewarding. So when it comes to dosage, I would say stick to the dosage of 40 milligrams per day. This was based on the studies that were done at Harvard. And back then, when this dose response studies were done, it was seen that 10 milligrams collagen, which translates to 40 milligram of UC-II, is what showed the best efficacy. And this is what we have done since 2002, the first study when we did, all the way till today. We have tested 40 milligram per day, and it has been found to be efficacious. So the dosage is kind of fixed on that. And the mechanism, oral tolerance, is also dose dependent, because if you see from the immunology standpoint, oral tolerance only work when you give the food, in this case, food or the protein at a small quantities, because you need to trigger that T regulator cells or the immune pathway, and it happens at a lower dose. Otherwise, the body, if you give a large amounts of it, then the body consider this as a food, and it just, the mechanism does not kick in. So 40 milligrams is the dose. As far as the interaction with food, our initial studies were done, and even now when we do the studies, we suggest that the subject takes it just before going to bed, because it's kind of easy before going to bed, just pop in. So the reason why we did was we wanted to avoid any sort of food matrix interaction back in 2002, 2009, when we did the studies. And then in 2009, what we did was we did a sub-analysis. We saw when did actually, we told the subjects to take it before dinner, but some of the subjects took it with food when we looked at the patient diaries, and some of them took after just before going to bed. And when we compare the efficacy of WOMAC and VAS pain score, the efficacy was same, which means whether you take it with food or without food, it is going to be efficacious. So that's the second thing I would highlight there. And then the third question, can you repeat that, Dr. Desai? The third point.
Third question is basically regarding the duration of UC-II treatment for OA.
Perfect. So as you know, we have done multiple studies now, which goes for 180 days or 24 weeks. So 6 months is what is the longest study we have, but it is advisable to take UC-II on a long duration. And this is the reason why I think Dr. Subhash had a very good point, because UC-II is not a miracle cure for anything. If the subject feels better, he or she is going to go to the market to grocery shopping or play with the kids, and we are going to damage this knee. We are using it on a day-to-day basis. And the mechanism of oral tolerance requires the antigen or the food protein to be fed over a long period of time. So in terms of the duration, the clinical studies have been done up to 6 months. I would do it up to 6 months. But once you take the subject off, the effect may last for some time, but then they may have to restart UC-II because they have started using their joints, they have started going walking. And it has taken, what I say to a lot of doctors who I speak with, and this is exactly what they tell the patient as well, that it has taken 40, 50, 60 years for them to damage their knee. How can they expect something to be cured in a matter of 1 month or 2 months or 6 months? So a long-term therapy with UC-II is recommended. And then the question comes about safety. And I would say the safety of UC-II is proven in clinical study. Plus, we have also done the standard toxicological battery of studies, which shows that UC-II is safe and well tolerated.
Dr. Zain, I think I want to have an extension of a question Dr. Sardar mentioned very interestingly, that he has noticed that the outcomes of TKR have been better when patients have been on UC-II. So does that probably correlate with one of the studies that you mentioned of the cartilage thickness which is there?
You're right, Dr. Desai. I think this is the first time, as Dr. Prasadt also mentioned, we have been asked so many times by doctor, does UC-II has any structure modifying effect? And until now, that was one thing that we wanted to check, do an ultrasound and see if there is any direct impact on cartilage. And for the first time, this study, which was done at University of Kyiv, showing an improvement of 17% in the cartilage thickness. I think like in the past, we have seen all the clinical outcomes, the standard classical outcome, WOMAC, VAS, Lekin, improved, but seeing it and objectively, a very objective measure where we can visibly see an increase in cartilage thickness is very exciting from the science standpoint, also from the clinician standpoint. So I would like to reiterate that point again and again. And we continue to do more research behind this brand to further unravel
name was announced, but not there.
Unravel the mechanistic aspect and the structure modifying effects of UC-II.
We have dinner also now, from 7:30. Are they going to take?
So, Dr. Prabhoo, sir, can I address the next question to you?
Can I add on to your?
Yes, sir. Please, sir.
Yeah. So, Dr. Jain, this ultrasound-based study, which showed that there's a cartilage regrowth, I think we should reevaluate this with the MR cardiogram, because that's much more accurate study in terms of finding the cartilage regrowth. Because ultrasound itself is a subjective study.
Correct.
So that actually puts a question mark, but it's a very good thing which we have come to know today. And I think we all should now target towards the MR cardiogram to understand the improvement in the cartilage level.
Thank you, sir.
Excellent point. That is a very excellent point.
Dr. Anish.
Yes, sir.
Dr. Anish. Yeah. So, actually, after a long time, after the spate of nutraceuticals, etc., have come for the treatment of osteoarthritis, we are really happy that there is some kind of convincing molecule which has really given us some justifiable reasons to give this in osteoarthritis, especially in not the very severe ones. But then we have something to bank on for the conservative management of osteoarthritis, and we are really happy that this molecule mostly serves the purpose of our conservative management overall. Okay, I mean those arthritic patients who have got deformities and they have some problems, severe problems where they cannot really walk. Now, those patients cannot be helped with conservative management, as all of us know. but in those cases, surgery is imperable. And that's the reason why I think that UC-II has solved it. May not be a miracle drug, but it is somewhere close to miracle drug, I would say.
Thank you, sir. I think a great point. My next question I would like to address to Dr. Subhash Jangid. Sir, what to say dictates your choice of a formulation of a UC-II? Because I think Dr. Prabhoo and several of the panelists mentioned that there are several combinations that have been used and are available in the market. So what really helps you in making a choice in terms of the formulation that you're using?
So, as far as the undenatured collagen is concerned, I would prefer to use this as the purest form if possible. And somehow my experience with the sachets is not very great, so I don't prefer sachets because most of my elderly patients somehow they have problem with the taste or the smell or whatever it is. So a tablet or the capsule form, most of the capsule form works really well for me. So there are a lot of combinations available which like they put everything in one basket, and that's I think probably is not the right idea because then you don't know what is working for the patient.
Thank you.
So I would prefer to use them in a purest form.
Yeah. So Dr. Sardar, I would like to address the same question to you in terms of your choice of formulation, and does any grade of osteoarthritis that is there that dictates your choice in terms of the formulation or in terms of the kind of combinations that you want to use?
In a way, yes. The whatever this nutraceutical part of it or the conservative part of the TKR, my point is that you use it in stages 1 and 2, but also in severe cases, because there are many severe cases who do not want an operation or who may not qualify for an operation. Now, giving this medicine and trying it out, there are some rare cases in which they improve, whatever may be the reason, the psychological reason or the actual reason, pharmaceutical reason. For those cases, they have delayed their replacements and they're quite happy about it, because when they do come with deformities and other problems and all that, then they're satisfied that they've undergone the whole gamut of conservative treatment and yes, they had to do it. So their satisfaction level is better. Now, apart from that, whatever combinations we use, the UC-II has to be an integral part. That is my conclusion after these years. And previously, we grew up on so many things like glucosamine and chondroitin and S-aminol adenosine acid, etc., thousands of combinations. Now, the main combination that I use would be a UC-II together with some other medicine which may be effective or not to that level of UC-II, but as an additional effect. But the bottom line is both have to be safe. That is the whole bottom line of it. And here UC-II is very good. So we'd be using that most of the time in the stage 1 and 2. And even in stage 3 and 4, who we know is not going to improve much, but to let them know that we have undergone that conservative treatment, we tried our best, and the TKR is the last available for a way out. And then they accept it much more properly. And their subsequent satisfaction level after TKR is better.
Sir, one more extension of question to you based on your vast experience with your patients. What do you think would be the other cases that you would have probably used or would like to use UC-II in your orthopedic practice?
Absolutely. The first thing that comes in mind is the frozen shoulder. Periarthritis shoulder, whether that is one of the not insoluble, but one of the difficult problems to really go about it. That is one case where I would love to. And the other cases would be whether the osteoarthritis in the other joints, especially the hips. There are certain cases of hips with avascular necrosis, young patients, whom the only opportunity, the reason that we have is probably a decoding operation, which is a conservative operation. And a THR and all that, that's too big for many of them, and especially at a young age, it's difficult to predict how long it will last. So in these cases, of early hip osteoarthritis would be an excellent way. I don't know whether this can be used in other cases of hip osteoarthritis, not osteoarthritis as such, but say it's an infective case of a hip osteoarthritis in which the cartilage is being damaged due to infection. And we know that the infection is controlled, it is burnt out, etc. But still there are certain problems in that, whether it can be used in those cases. Ankle osteoarthritis is another big thing which I would really want. Extending generally the whole thing to beyond knee osteoarthritis and hip osteoarthritis would be one of my dreams.
Thank you, sir. Thank you. Great insights. Dr. Prasadt, one question to you that I have in my mind is that again, there are several nutraceutical formulations available or nutraceutical products available currently in the market, and you have been using them for some time. And you get patients also who come to you for the replacement surgeries. So in your opinion, do you see that UC-II along with any other nutraceutical that you have experienced in your practice would be a good combinations, or any combinations that comes to your mind that would add to the whole armamentarium of conservative management of osteoarthritis?
Frankly, I'll tell you, I have been using the pure collagen. The combination is given by pharmaceutical companies. We never ask, I think, and still I use them, all the combination, but I don't have any comparative data which medicine is working. I always knew that yes, the UC works in my patient as far as the symptoms are concerned, as far as the walking ability is concerned, and the gait which I can always evaluate. And we have done a lot of video assessment of the gait also. But two things which I would like to emphasize. Number one is the duration of the therapy with UC-II. And I have got more than double figure of patients where it has been used for more than 5 years. And that includes a good couple of doctors, physicians. And all of them, I'll tell you, have been preparing for surgery. And unfortunately or fortunately for the patient, it has been delayed now. And that includes very close friends. And they also read, because they're doctors, they also read a lot about the collagen before using it repeatedly. So they try to, and the other negative point, whenever they left it for a couple of months, the symptoms started coming back. So that's a dangerous thing, which I think Dr. Jain will say more. So that's very important thing, number one. Number two, I have used it in other places like Dr. Sardar is saying, and you will be surprised, I use it post-operative of TKR in my patients with anterior knee pain. And it was only on the belief that maybe I do not resurface the patella in my cases now. So maybe only for those patients where some knee pain comes, and more than 60% or 70% of them do get relief after using collagen for 3 to 4 weeks. So these are one extension. And definitely I also use for osteoarthritis of the hip, whether it's usually secondary we get. So we definitely use it for that. And I have got a friend, a spine surgeon in Delhi, I think Dr. Subhash may be knowing, he uses it for all the spine osteoarthritis patients. So this is extended. I do not have a spine patient, but I've heard it, and he really talks very positively about the collagen for his spine patients.
Dr. Anish, I would like to ask question to Dr. Zain.
Yes, sir.
What is his experience, or what has he done? Any research on rheumatoid arthritis and secondary arthritis following rheumatoid? And has he got any experience in that?
That's a great question, Dr. Prabhoo. So I think we as a company, we have not ventured into rheumatoid arthritis with this, because in US and many other places, for example, in Europe, UC-II is considered as a supplement. So it's a big no-no for us to do a rheumatoid arthritis study. But the concept of native type 2 collagen and how it all evolved at New York School of Medicine and Harvard, the studies were done with rheumatoid arthritis. There is a group back in 1993, David Trentham et al. At Harvard, and I would be happy to share these papers with you. He did the study in rheumatoid arthritis patients with supplementing them with native type 2 collagen, and showed that it basically reduced the swollen joints and all the rheumatoid arthritis related scores. In fact, this was a study with 60 RA patients, 30 of them were on placebo, 30 were there on the native type 2 collagen. And you'll be surprised that 4 of these patients had a complete remission of that RA. And after that, there are 2 or 3 studies that has been done at Harvard in RA patients, rheumatoid arthritis patients. So there is a lot of information that exists already for the benefit of this native type 2 collagen for RA indication as well.
Thank you, Dr. Zain.
Are we right if we use it in the rheumatoid cases? Technically and politically?
Technically would be, I would say yes. The only thing is, as a supplement manufacturer, like we are reserved in countries like US and Europe, but in India, if the local regulations allow it, then definitely you are the doctor at the end of the day. And I think it's definitely your choice to determine what is best for the patient. And I'll give you one example. So a little over 3 years ago, when I came to India and I met quite a few orthopedicians and rheumatologists in Mumbai, Delhi, and in Bangalore. And at that time, see, I'm a researcher, so I get driven by new research, new finding. But at the end of the day, it's the clinician. When you give it to your patient and you see the benefit, that is what is rewarding. And that time I used to tell all these doctors that don't take my words, don't take the research that I have done. Just give it to your patient and see how they feel, and then we can talk. And I'm really happy today to see all the good feedback that you are receiving from your patients for this molecule.
So Dr. Anish, there is a food for thought given by Dr. Zain that we could do some studies. All these panelists who are there, national repute, I'm sure we'll be able to gather some 500 patients of rheumatoid, and we could give them and try this. And I think that would help Dr. Zain to prove his point, probably.
Yes. Dr. Gokulraj, one question that I have, I think, which we still now haven't addressed is there any kind of your experience in terms of specific age groups, men, women, where this product you feel is better? And we of course got a feedback from our expert panel in terms of the severity of the OA. But do you have any experience in terms of the age of the patient and the arthritis, and in terms of the any gender things that are there?
He's working, I think.
Dr. Gokulraj, can we, if you're there at this point? Okay, so I will like to direct that question to Dr. Zain. So Zain, Dr. Zain, any feedback on this in terms of the patients in terms of their age or in terms of related to their the gender things which are there?
So I think it's a great question, and I would answer this question based on the clinical evidence that we have for this molecule. So let me start number one, the osteoarthritis clinical studies that we have done. The age range of the patient was 30 years on the low side, 75 on the high side. And we have seen the efficacy when in this age demographics. So that is the osteoarthritic population. Now, I'll take one leap forward, especially here in US, Canada, also in Europe. People are more on preventative side. So when they are healthy, they still try to take supplements that will keep their joints functional and keep all this osteoarthritis at bay. So the healthy subject studies that we have done, and the one that was published just last month in Journal of Integrative and Complementary Medicine, the age range we had used was 20 years old on the lower side and 55 years old on the upper side. So we did see that UC-II improved knee flexion in this younger demographics as well. And knee flexion is very important. You are expert here, but just 3 to 5 degree loss of knee flexion or extension can determine the development of OA down the road. So in this study, which was published, we saw a 3 degree improvement in knee flexion over a 6-month period. So that further, which is also, by the way, is an objective measure. So the point I'm trying to make to answer specifically your age, we have data from as young as 20 years old to 75 years old. So that's the answer to your age question. As far as male and female, yes, osteoarthritis is kind of more prevalent in female. That's what the number says us. So again, we did quite a bit of sub-analysis, and especially the mobility study, the last one that I'm talking about, the healthy subject. When we looked at male and female, we saw kind of an interesting dynamics there. So the female subject tended to have a higher improvement in knee flexion compared to the male subject. But when we looked at the mobility, daily number of step count and physical activity, males were significantly higher than female. So the point I'm trying to make is, yes, it is beneficial to both genders, male and female, to see the effects on joint flexibility and mobility from UC-II.
Thank you, Zain, Dr. Zain, for this answer. And I think Dr.
Anish would like to add one more thing here.
Yes, sir.
That I also use this molecule for the younger patients who have the chondral damage. When we do the arthroscopy, we do ACL or meniscus repair in them. We found there's a cartilage damage. So I use this molecule in those patients. They really do very well. And younger patients have very good cartilage regeneration potential, frankly speaking. So it works really well for the younger patients. The moment patient goes more than 60, definitely the body's regeneration potential is less. But yes, younger patients really do well, no doubt about that.
Yeah. Thanks, sir. Dr. Zain, one question that I have before I think we throw open the whole platform for the audience to raise any questions. There's Dr. Prabhoo mentioned about clinical studies. So what is the kind of evidence that you think we in India should be looking at? And I think our expert panels also would give their opinion. But according to you being a researcher and an extensive data that you have generated on this product, what would you think would be the answers that we should be looking for from India perspective?
I think from the India perspective, definitely, I would say more looking at today's audience. I think the studies that were done in osteoarthritis that we have done with grade 2 and 3. So that does add a compelling body of evidence, clinical evidence that the doctors can look at. And as Dr. Subhash mentioned, younger demographics. I think another application is sports medicine. Keep that in mind as well.
Yes.
So, and that's where you should look at the studies that are done in healthy subjects, where subjects are having pain after physical activity, which is actually doing after playing cricket or soccer, for example. So that is how I would put it. And always the clinicians are driven by EBM, evidence-based medicine, and they want to see a constellation of studies and want to see the complete picture. So all the 11 publications that we have does make a compelling evidence. And I think that's what should be looked at by the doctors when they are evaluating this molecule or prescribing it to their patient in their regular clinic.
Thanks, Dr. Zain.
One entity that I would think is that chondromalacia pateli. Okay, when this is a condition, probably this is one condition where we should try and do some kind of studies.
Yes, sir.
I think Dr. Subhash Jangid, who is an arthroscopist, would also vouch for that.
Yes. So, Dr. Sardar, based on your rich experience, any suggestions in terms of what evidence that we should look for from an India perspective, if we should look for?
Yeah, I think there are a number of persons in the younger age group who do develop osteoarthritis because of various reasons. And whether or not this medicine will work, the best part of it is it will do no harm. And if that is the thing, then the way it works, it should be effective also in these cases. Like a young patient has a cartilage injury, even without an arthroscopy, you've done an MRI and you've seen cartilage damage, and the patient is not responding well to other things. I think this is the way which we can find out by giving it to the younger age group also. Basically because it causes no harm.
Thank you, sir.
In traumatic cases like intra-articular fractures, where we have operated or we have treated them conservatively. So intra-articular fractures, where there is certainly cartilage damage, also some kind of bone contusion which occurs peri-articular region. In such cases, we could also try.
Thank you, sir. Dr. Prasadt, any thoughts on this?
I think I will just say that I always means capital. I always use collagen supplement for all my articular injury patients. And that's it. Young, old, I don't mind. I do use because I read about it, how the collagen works, and I read extensively before using it for long term, because none of the companies have told me to use it for 5 years and more. So I had to read more about whether it's going to create any harm, though there were no publications, but I didn't find anything which is adverse here. So that's why I'm using it. I use it for wherever I think there's a cartilage damage. It's something which is going to help in cartilage regeneration. If something can help in cartilage regeneration in older people, it should help better in younger individuals as well. So that was the idea. So I always use. That's why I said I use it for my post-TKR patient, where they have got some evidence of anterior knee pain. I supplement them. I don't regret it.
Thank you, sir. Thank you, sir. Dr. Subhash, any thoughts on this?
So I would say that it's definitely as Dr. Prabhoo also mentioned, that we should definitely look for these patients. I definitely do them. And I think we all are giving this to our patients, but it's not been documented. So documentation is very, very important. I think data collection we all need to focus on. And I can share 2 or 3 cases of elderly patients, like who had an acetabulum fracture, maybe like 3-4 years back, and they're 75 years of age, and they are having a hip joint pain, but they are like not suitable for any kind of surgery. They don't want a surgery. And I gave this molecule to them, and they're like, we are happy now. We don't need any kind of surgery. So it's that kind of molecule which works really well into the right kind of candidate, which is motivated to avoid the surgery, do proper physical activities, and they're at the borderline of the advanced arthritis. So just before that, it really works well. And
thank you,
obviously, everything has to be added to that.
Yes, thank you, sir. Vaishali, if there are any questions that have been raised by any of the audience, then we can just read them out for any of the panelists.
Yes, surely.
Any of the questions that we haven't addressed till now, something which is different from that has already been extensively discussed by the panel members.
Meanwhile, Dr. Anish, I think as like Vaishali, are there questions or no?
Yeah, so there was a question which is on the different indication apart from the osteoarthritis, if it is a T.
That's been covered.
Okay. So that was the question which was raised. So I think so the most of the questions looks like the repetitive. So we're not going ahead with those questions which are already been addressed by all the doctors. So Dr. Anish, any
no? So I think I would like to thank all the panelists and hand back over to you, Vaishali, to close the webinar, and thank you to all my esteemed panelists for helping me out with this question answer session.
Dr. Anish, I would like to request Dr. Zain to physically come back again and address us and give his extensive experience in person. I think, of course, online was good, but it is half good.
Sure, sir.
So, Dr. Zain, you are invited.
Thank you, Dr. Prabhoo. It would be a pleasure to meet in person, and I would definitely look forward to meeting with all of you, and kind of we can share more stories from
you have 40,000 orthopedic surgeons would be waiting for you.
Okay, thank you.
Thank you, Dr. Prasadt, Dr. Sardar, Dr. Subhash.
Dr. Prabhoo meeting in fortnight. After a fortnight, we are meeting again.
Yes, next weekend.
In person.
Thank you. Thank you, Dr. Anish.
Thank you, sir.
Thank you, Dr. Vaishali, and it was great meeting all of you.
So thank you so much, everyone, for joining the program and having unwavering attention throughout this program. And also, I hope this program certainly benefited from your breadth of the knowledge and depth of expertise to everyone. And also here, I would like to thank, all the panelist member and also the Dr. Zain Saiyed for a valuable contribution from the UC-II point of view, and also the Lonza team, and our eminent panelist, which is Dr. Prabhoo, Dr. Indrajit Sardar, Dr. Subhash Jangid, Dr. A.S. Prasadt, and Dr. Gokulraj, for enlightening us with their clinical practice and experiences, and also the usage of UC-II in the management of osteoarthritis. But last but not the least, thank you so much, Dr. Anish Desai, for moderating our entire session. And I would like to thank you. I mean, it was really a wonderful session with all of you. And we have all, have enlightened the thoughts and the usage and the experiences which we have shared. So thank you everyone for your valuable time and valuable experiences. Thank you so much.
Thank you.
Thank you very much.
Thank you very much.
Thank you, everyone. Thank you so much.
Thank you. Bye.